bleeding, and his talk today is continuing work on the mobile stroke unit. So please, Jim, take it away.
Okay, thank you. You all can hear me okay?
Yep.
And I've been always told not to start a talk with an apology, but if you hear dogs barking in the background, that's my support group. Anyway, today I'm going to talk about improving intravenous thrombolysis. So there may be some of you on the call or at the lecture who are more or less familiar with where we are with acute stroke therapy. So I will have a few background slides, but I want to emphasize that I'm talking about intravenous thrombolysis predominantly today. I do have some conflicts, or at least disclosures. I'm a consultant for a company that makes mobile stroke units. I get grant support from Genentech for a study that I'm going to talk about, giving second dose of TNK. I'm on the scientific advisory board of a company that helps with developing a test for detecting DOACs in the urine. I'll try to keep my comments as objective as possible. But as Dr. Sheth pointed out this morning in our stroke chat, that he published an article recently in SFIN about all the occult biases that can occur in all of our brains. So we always have to be aware of them. But I think I'll be as objective as possible. So the story with IV thrombolysis, sort of the first chapter, ended in 1995 with the approval of TPA for acute ischemic stroke. These are the investigators, including myself and Patty Bertina, who's still the nurse on the mobile stroke unit, is a coordinator for our center back in 1995. And what we showed is that with what thrombolysis does is, of course, here's an occluded middle cerebral artery, and although TPA doesn't work predictably in acute in such large vessel occlusions, I'm going to talk a lot more about large vessel occlusions versus smaller ones in a few minutes. But this is what you try to achieve with thrombolysis, which of course is recanalization of the vessel. And what we showed is that the odds of a non-disabled outcome increase with TPA compared to, this is the no benefit line, the odds being 1. Anything more than 1 obviously is a significant benefit. These are the 95% confidence intervals. And you can see that the benefit occurred with treatment within 180 minutes, but was definitely increasing with earlier treatment. There was a lot of debate after that study was published, but it finally, and of course, bleeding is a complication, but as it turns out, bleeding, although it's a complication, turns out not to be the main limitation of treatment. The main limitation is lack of benefit, which I'll come to in a minute. But these initial results were corroborated by subsequent studies in thousands of patients, confirming the benefit of IV thrombolysis. In this case, all these were done with TPA, or tissue plasminogen activator. I'll remind you, and I'll talk more about TNK in a few minutes, but tenecteplase is also a tissue plasminogen activator, which is slightly modified from the original Activase TPA molecule. But there's no question that thrombolysis works and that it's time-related. Importantly, though, the field, and I'd like to say the field has been hijacked by endovascular therapy. That's kind of a negative, pejorative comment, because endovascular therapy has been a revolution for us in terms of good outcome. But in terms of the attention of our fellows and the attention of our clinical trials, and I do think even in at least even among our faculties, finding the patients for endovascular therapy is almost like become the priority rather than speeding and finding patients for thrombolysis. Yet thrombolysis is never going to disappear, or at least not in the near future, as the most common treatment for our patients. So this is a heat diagram from the Greater Kentucky Cincinnati database showing the NIH stroke scale scores and the frequency of NIH stroke scale scores in acute ischemic stroke patients presenting to the emergency department. We know that the presence of large vessel occlusions, which are the target for endovascular therapy, is correlated with the NIH stroke scale score. And it's not until you get to an NIH stroke scale score of 10 or higher that you have a high yield of large vessel occlusions that are candidates for endovascular therapy. The vast majority of patients, really 2/3 at least, of acute ischemic stroke patients that come to the emergency room do not harbor large vessel occlusions and are candidates for IV therapy. And even the patients who get endovascular therapy, particularly if they're being transferred and there's a delay before they get endovascular therapy, they're also candidates for IV therapy. So I'm going to talk about how to enhance IV thrombolysis, but I just want to point out that it's applicable in the world of endovascular thrombectomy. Okay, so and again, for those of you who are not strokologists, it's important to recognize that the occlusions can occur anywhere on the arterial tree, and the large vessel occlusions that are largely targets for endovascular therapy are carotid, M1, the proximal segment of the middle cerebral, and the basilar. And they are also candidates, as I pointed out, to get endovascular IV therapy as well. The medium vessel occlusions and the distal vessel occlusions have yet to be proven to be targets for endovascular therapy, though there is a lot of attention on expanding catheter-based therapies to lesions of the second and third order of the middle cerebral artery and the anterior first divisions of the anterior and of the posterior cerebral artery. And hopefully we will develop the technology to be able to do that. Until then, those are targets for IV therapy. And then all the distal occlusions are candidates for IV therapy. So currently, I'll show you the statistics, but largely, probably really only 30% or so of our strokes that we see are large vessel occlusions, and the rest are candidates for IV therapy only. So with that preamble, how moving forward can we improve on IV thrombolysis as we do it now? And there are three ways to do this: more therapy, faster therapy, and stronger therapy. I don't have time to really talk about more therapy at this point. I'm going to skip that. That's a whole another lecture. But I'd suffice it to say that if we could double, right now only about 10% of acute ischemic stroke patients arrive in time and to appropriate hospitals to receive our therapies, whether they're intravenous or endovascular. Maybe a little north of 10% now, maybe even 15%. If we could double that percentage, that would have a greater impact than anything I'm going to talk about in terms of speeding therapy or making it stronger. But as I said, that's a whole nother lecture, and maybe I'll have time at the end to make a few comments. Why are my slides not advancing? Okay, for some reason, my slides are not advancing. Navigate forward. Forward actions. I can go backwards. Okay. So, thank you, whoever did that. Okay, so faster. And the way to do this is with mobile stroke units. Mobile stroke units don't have to be fancy. They're basically a ambulance with a CT scanner on board, a physician, a nurse, a CT tech, and one or two paramedics. And the physician can be replaced by, not replaced, but can be on board or by telemedicine. And the CT scanner is on wheels, and it can produce very serviceable CT angiography as well on board. So I showed you that there's a relationship between IV thrombolysis and time, and I showed you on an earlier slide that it appeared that that relationship was linear, but as we get more information on patients treated in the first hour, we see that it's not so linear. Actually, with earlier treatment, we get an exponential increase in the likelihood of a good outcome. And the only way to achieve that is by bringing the treatment to the patient in a mobile stroke unit. So how do mobile stroke units work? When a 911 call comes in, the mobile stroke unit gets dispatched along with the fire department. We arrive on scene simultaneously. And if the patient's having a stroke, they get put in the mobile stroke unit. And we've done a study, and and others have done the same. If the patient is managed by the fire department in an urban area, it usually takes about 15 to 20 minutes to get the patient bundled up from the scene and transported to the emergency department. And then about 30 to 45 minutes of door to needle time in the emergency department to get the CT scan done and the patient treated. Well, during that, if we arrive on scene with the mobile stroke unit, over the next 15 to 20 minutes after arrival, we can get that patient treated on scene. So during the same interval that the fire department would be transporting the patient, we're getting the patient treated. So we save the entire door to needle time in most emergency rooms, which is about 30 to 45 minutes in an urban area. So all sorts of people in most stroke centers say, well, we don't need a mobile stroke unit because there's a comprehensive stroke center, multiple comprehensive stroke centers or primary stroke centers, and we can get the patient to the hospital within minutes. But they forget the fact we can get the patient treated on scene within minutes, and we save the entire door to needle time. So every study that's been done with mobile stroke units has shown about the same amount of savings of about 30 to 40 minutes of time. We did this study, published it, 7 other sites in the United States that developed mobile stroke units after we did. Published this in the New England Journal a few years ago. I won't belabor the data, but I want to show you a few points that with standard management, this is not TPA alone. This is patients who are eligible for IV therapy and get managed by the fire department, as opposed to the same patients who are managed faster on a mobile stroke unit, about 30 minutes faster. You could see the shift to better outcomes. Even with mobile stroke units and with this shift to better outcomes, though, I'll point out with this slide, and I'll emphasize it again, only slightly north of 50% of patients end up with a normal or near normal exam at 90 days. So we can do better. The benefit of mobile stroke units, we think, is it was driven by patients treated in the first hour, which was 10 times more common in the mobile stroke unit group. These are a heat graph of patients treated in the first hour versus patients treated later, or patients in the emergency room where they're almost only 3% were treated in the first hour. So 10 times more likely with the mobile stroke unit to be treated in the first hour. And if you take all the patients treated and you look at treatment in the first hour versus treatment after the first hour, you anchor your results with first hour treatment. If patients are treated after the first hour, there's a gradual decay in the likelihood of a good outcome. If they could be treated in the first hour, every few minutes, there's not a gradual increase, but a very sharp increase in the likelihood of a good outcome, to the point where if we get patients treated within the first 50 minutes or so, there's about an 80% chance that patient's going to get back to normal. And these are not TIAs. These are averted strokes, because these are patients that are later adjudicated as having most likely had a stroke because an arterial occlusion was seen, or they ended up with some lesion on their MRI scan, even though they ended up disabled. So, as I pointed out, in an urban area where you have mobile stroke unit and you have stroke centers fairly close, what we save is the door to needle time. And the real benefit of mobile stroke units in urban areas is getting the patients treated in the first hour. Mobile stroke unit arrives, gets the patient quickly to the comprehensive stroke center, or to the stroke center, but before doing that, gets that IV TPA done on scene hopefully within an hour of symptom onset. But one of the common questions we get, of course, is whether mobile stroke units are applicable to rural areas. And this is where it comes into getting more patients treated. In a rural area, you have the patient out here a long distance away from a stroke center where they can get treated. So if your mobile stroke unit gets dispatched from the distant stroke center at the same time the fire department picks up the distal patient, and they meet somewhere in between by rendezvous, and then treat the patient there at the roadside or in a parking lot somewhere, and then transports the patient to the stroke center, you can actually save even more time. If it's, let's say, an hour's transport for the patient to get to the stroke center, and you can meet them halfway, you're saving 30 minutes of transport time in addition to the door to needle time. And so this actually has been shown in Gainesville, where they are surrounded by 6 rural counties. Gainesville isn't that big a town, so in order to keep their mobile stroke unit busy, they not only respond to stroke codes in the Gainesville metropolitan area, but in the 6 rural counties around them. And what they found is when they pick up a patient in one of these rural counties, they save an hour, 56 minutes. Their treatment time from alert to treatment time using rendezvous in these rural areas was 41 minutes, compared to if the patient was brought in by the fire department, it's almost 100 minutes. So they save almost an hour compared to the 30 or some odd minutes we save in an urban area. So although I wanted to point out that treating more patients is one of the objectives, one way to treat more patients is to develop mobile stroke units in rural areas. Now, this slide was supposed to be hidden, but this is a recent geospatial analysis that Ryan Rampool at the School of Public Health did for Texas. And I mentioned that we save, that it takes 90 minutes or so for fire department management. So if we had 14 strategically placed mobile stroke units in these comprehensive stroke centers around the state, and you allowed for a 90-minute rendezvous, you could treat 100% of the entire population of Texas, get them treated theoretically, if they called 911, theoretically treated within 3 hours of symptom onset. Okay, so that's all I want to talk about faster. In my opinion, that is a potent way to improve on thrombolysis, and what we have been supporting and proposing for years here in Houston, have been demonstrating with our mobile stroke unit. Okay, well, what about stronger treatment? Well, as I pointed out, outside of treatment within the first golden hour, about at least 50% of patients with current IV therapy will not have a good outcome. And even in treatment in the first hour, there's going to be a proportion who don't have a good outcome. And this corresponds to failure to achieve partial or complete recanalization. And as I'll show you, recanalization also only occurs in about 50% of patients with thrombolysis. Now, why does this happen? Well, there's extension of the clot and also failure to reperfuse the microcirculation. Even if we get the artery open, the clot may reform, may extend, or we may fail to reperfuse in the microcirculation. I'll come back to that in a minute. So we know that recanalization of the parent artery correlates with outcome. And we also know that faster is better. This is from early ultrasound studies, which showed the time from symptom onset and the probability of favorable outcome. So this is the time from symptom onset to the time that recanalization was achieved. And this is the likelihood of better outcome. So you can see that the earlier we get the artery open, it's not just the earlier we treat the patient, but the earlier we get the artery open, the more likely the outcome. So when we see better outcome with earlier treatment, it's the better outcome is due to recanalization. That's how thrombolytics work. In addition, the time from symptom onset is related to the likelihood of getting the artery open. So the earlier we treat the patient, the more likely we are to get the artery open. All of this follows, but we have data now to support this. But this is an important point I want to make, is that with our treatment within the first 3 hours, or when we get our, most of the time when we get our IV thrombolytic therapy into the patient, it's here where the probability of thrombus resolution is only about 60%. When we get patients treated earlier, the likelihood of getting the artery open, as I pointed out earlier, is much higher. But this is where we are sitting with most of our patients in the emergency room when we're treating them with IV thrombolysis. We're getting the artery open at the recanalizing the vessel at best in 60%. Now, I'm not just talking about LVOs now, I'm talking about all occlusions. And we've been able to see this with ultrasound early on, back when we first did transcranial Doppler in the emergency room. We found that these are the proportions of patients who either didn't recanalize at all, had partial recanalization, had complete recanalization, or had complete recanalization and then reocclusion. So if you count up the patients that reoccluded or had no recanalization, it was about 50%. So all these statistics come together. About 50% of the time, we're going to get the artery open with IV thrombolysis, and that correlates with the likelihood of a good outcome. This is a patient we just treated 2 days ago on the mobile stroke unit. 95-year-old. This is one of the problems why we don't get complete benefit with IV thrombolysis. Patient, 95-year-old woman, NIH stroke scale score of 21, had a proximal, came in, had a proximal middle cerebral artery occlusion. I think we can all see that. Received TNK on the mobile stroke unit a little bit more than an hour after symptom onset. This CTA was done in the emergency room. So at that time, she had this occlusion, and it was elected not to take her to the, because of her age and her advanced directive, she did not go to endovascular therapy. And this is her CT angio later on, when it was repeated a few hours later. She had improved to an NIH stroke scale score, and she had a more distal M2 occlusion. So the clot had moved distally. So this is partial recanalization. Could it have been complete recanalization and reembolization? But the fact is, it's partial recanalization that we achieve very frequently with IV thrombolysis. Not only that, clots can extend. The parent clot can just move distally, and you can see that with susceptibility imaging. This is admission MRI scan. You can see the clot, and you can see on a follow-up scan on susceptibility clot, you can see the same thing. Here, it's moving distally. So, and here, proximal, you can see it more distal. So, and this more distal migration of the clot correlates with neurological worsening. So clots are a dynamic situation. You do a transcranial Doppler or a CT angio in the emergency room. If you repeat it a few minutes later, whether or not you give thrombolytics, it's likely to be different. And if you give thrombolytics, it's very likely to be different, either more distal or fragmented. And then, of course, again, thanks to Dr. Barreto for this slide that I used for years. This is a patient with a middle cerebral artery occlusion. You can see on the late phase, the lack of perfusion. And then after thrombolysis, you can see the artery is open, but you can see the very delayed flow in the microcirculation. So this was described as no reflow years ago by Adalbert Ames in total circulatory arrest, when he uh, arrested entirely the circulation. I believe it was primates, I can't remember. But in any case, and then reperfused these animals. There was no reperfusion in the micro vessels in the cortex. They were plugged up and never were able to reflow in these vessels. And this was coined the no reflow phenomenon. And it's very likely that to some extent, this is occurring as well, even after we get reocclusion in the most central parts of the area where flow is reduced the most. Okay, so that's the problem, is that with IV thrombolysis, it works. It works better if we can do it faster, but it doesn't work all the time. So how that leads us to stronger. How can we do better? So what are some of the strategies? Well, what about a higher single dose? We only have given 0.9 milligrams per kilogram of Activase or 0.25 milligrams per kilogram of tenecteplase. How do we know that higher doses aren't better? Well, we don't know that much with Activase or TPA because the pilot studies were very small, but these are the data from the pilot trials of IV TPA. And it wasn't until we got above 0.85. When we got above 0.85 milligrams per kilogram, we had no bleeding before that. But when we got above 0.85 to 0.95, we started to see bleeding. So why did we use 0.9 and not 0.85? We rounded it off. We figured clinicians would have a harder time figuring out 0.85. So we just rounded it to 0.9, and that's how 0.9 dose got chosen. And it turns out that when we lower the dose, we do get, as is done often in Asia, although I think that's done less and less now, we get perhaps slightly less bleeding and probably slightly less efficacy. But for the most part, I think most of us were happy with the 0.9 dose, but I think not any evidence that going higher, reasonable evidence that if we went higher, we'd get it into bleeding. What about with TNK? Well, this was an early study by Clark Haley that we also participated in, where we used accelerated doses of TNK. We actually went up to 0.5, but you can see that we started to get into bleeding when we got above the 0.25 dose, and we went to 0.4. And when we went to 0.5, it definitely got more bleeding. And so and then further studies were done, including the NOR test trial and others that used additional doses, and with both 0.25 and 0.4 doses, and we found that there didn't seem to be any greater efficacy by moving from a 0.25 to 0.4 dose compared to TPA alone. But there was a suggestion from these studies of more bleeding. So that's the data we have with going to a higher dose. So bottom line is, I don't think going to a higher dose, single dose, is the answer. Well, what about a better lytic drugs? There was a lot of hope that tenecteplase would turn out to be better, but in fact, it's really non-inferior. Now, we all use tenecteplase. I pointed out it's also a tissue plasminogen activator because it's more convenient, but the data show that at least achieving a Rankin score of 0.1 or 0.2 with alteplase compared to tenecteplase, there really isn't any difference. And this is a slide I showed at the SVIN a few years ago. So I always said that Thai is like kissing your sister, and we should stop our preoccupation with TNK and let's find something more exciting. And there are newer drugs on the horizon. And there's alpha-2 antiplasmin, which instead of using tissue plasminogen activator, something that blocks plasmin, would work, might have the same effect, might be safer, might be more effective. Studies are going on, as well as drugs that may work on von Willebrand factor. But for now, we don't have a newer lytic drug that works better than Activase. And will we be able to make a difference? Maybe we can find better outcome with a better lytic. My own feeling is the benefit will be fairly marginal. Okay, what about coupling thrombolytics with antithrombotic drugs? Well, we tried that as well in the MOST trial, where we combined of TPA or TNK in the later parts of the trial with either argatroban, the direct thrombin inhibitor argatroban, or eptifibatide. And we used doses that seem to have worked in pilot studies that seem to be safe. And these drugs were started soon, either during or soon after the TPA infusion, or the TNK bolus. So there was thrombolytics still on board at the time these drugs were given. Now, we do know that dual antiplatelets work when given after thrombolytics, and there have been recent studies from China that show that dual antiplatelets started soon after thrombolytics prevent neurologic deterioration. And there's a recent study also showing, just published in the New England Journal, that the GP2B3A antagonist tirofiban also prevents neurologic deterioration when started after thrombolytics. So those are probably, I do think that's definitely a strategy that works, which is to give, instead of waiting 24 hours to start antiplatelet therapy, we should do it more earlier. But I don't think that's amplifying thrombolysis or preventing reocclusion so much as, well, it may be preventing reocclusion, but I don't think it's targeting the microcirculation or amplifying the lytic effect of the thrombolysis. I think we're preventing secondary events with those therapies that we're starting after IV thrombolysis. Okay, so what about extending endovascular therapy beyond the LVO, and we've tried that also with these studies of using endovascular therapy for MEVOs. All of our stroke fellows are familiar with these studies that have just been presented or published, and they show that with using endovascular therapy in these smaller vessels, right now with current technology, we're getting into trouble with complications and not getting benefit. Can we do better? I think we can. We hopefully, I'm not an interventionist, but I do think that better catheter technology may help us with MEVOs. But I'll point out that MEVOs are only probably about 20% at most of our small vessel occlusions, or of our patients qualifying for endovascular therapy. So I think that I thought I had this on a slide. I think I did on that first slide. I think that LVOs are probably about 20% of our IV therapy candidates. I think MEVOs are maybe about 20%. So I think together, the two of them probably comprise about 40 to 50% of our patients. But about 50% of our thrombolysis candidates are distal occlusions beyond something that we could even think that we were going to be able to approach with our catheters. And so I don't think endovascular therapy is the answer entirely for improving on thrombolysis. So what do I think are the strategies? Well, I think coupling further IV therapy, further thrombolysis with endovascular therapy for LVOs is definitely an exciting way to go. This was shown on the CHOICE trial, where patients who got endovascular therapy received IA alteplase after endovascular therapy, and they found rather dramatic improvement with that dual therapy. And half these patients had also received intravenous alteplase prior to the endovascular therapy. And most importantly, it was safe. And there was no interaction in terms of safety between whether patients got intravenous therapy or not. So it was just as safe whether the patients received intravenous therapy prior to their endovascular therapy. So I do think giving thrombolytics, it's not the title of not the purpose of my talk, because I'm talking about systemic and IV thrombolysis, but I do think giving IA thrombolytics after endovascular therapy is definitely a strategy worth further exploration, and including exploration of the dose. Uh, the doses used in these studies were about a quarter to a half of what the intravenous dose is, but of course the availability is going to be higher at the clot. Okay, so what other approaches is possibly giving more than one dose? I've hinted at this in the past, and or in my previous comments. There are some data to support this. This is a study done in France. Actually, there was an earlier study in patients with large vessel occlusions. Persisting large vessel occlusions, actually, this study was done in the West Indies, I think, where they didn't have endovascular capability. And so they happened to give a second dose of TPA in patients who had large vessel occlusions. And in a small study, which was published in Stroke, I think about 10 years ago, showed a a small series, but showed safety and better outcome. And anyway, Dr. Chausen, who I don't know, then published this trial in 2024 in France. They had two centers. All the patients qualified for intravenous therapy, and they had a MEVO, documented arterial occlusion, on their MRI scan. Did not have endovascular therapy. One center, they just gave IV alteplase. That was the standard treatment. The other center, they repeated the MRA after an hour, and if the patient still had an arterial occlusion, they gave full dose of tenecteplase. About 150 patients in each arm, and they found that with the dual therapy, recanalization rates were substantially higher, no difference in the rate of bleeding, and much higher rate of excellent outcome. Highly suggestive, but this was not a randomized trial. These centers, the patients were propensity matched, but it is intriguing. So, and the pharmacokinetics of TNK support this because, well, first of all, I've shown you that there's usually residual clot. So if there's a residual clot, the TNK has its maximal effect at 30 minutes. So it binds instantaneously, both TPA and TNK. When it's given, it instantaneously binds to fibrin receptors. But then it gets washed away. Its maximal effect is at 30 minutes, and its circulating half-life is about 30 minutes. So if there's residual clot or recurrent clot, that means that there's still substrate in the circulation for additional TNK or given after it starts washing away from the clot and washing out. In fact, after 60 minutes, only 15% of TNK is left circulating. As I pointed out, residual clot is likely still present in at least 50% of cases. So it suggests that a second dose might be rational and safe 45 to 60 minutes or so after the first dose. So this is what we propose. here is a study that's registered. We've finally just gotten all the paperwork signed, budget off, and all residue. We're scheduled to go live on August 11th. Um, Patients are not LVO, not EVT candidates. Um, they have to have a disabling stroke. They have to have received their first dose within 3 hours of symptom onset, and then and uh, and the second dose within 4.5 hours of symptom onset. And of course, their CT scan has to show no bleeding. So what happened is patient comes in, either in the mobile stroke unit or in the emergency room. They meet all standard criteria. They get their TNK. If their NIH stroke scale score is over 6, you get informed consent to participate in the trial. Then we keep repeating the NIH stroke scale score. After 45 minutes, if it's still over 6, then they're candidates. Now, they may get better and then get worse, or they may have a 20 and go down to a 6. But if it's still 6 after 45 minutes, repeat the CT scan, make sure they don't have any blood, they're still candidates. And if so, then they get their second dose, and that's when they're enrolled. And then, of course, we do the usual follow-up, and the primary outcome is symptomatic bleeding. And we're just going to enroll 20 patients to demonstrate that there's no substantial increase in bleeding. Now, you might ask, why are we using not doing a repeat CT angio or MR angio? Well, first of all, from a practical standpoint, demonstrating that clot is still present, we cannot predictably get an MRA in our emergency room quickly enough to be able to screen the patient for a second dose. And CT angio would be too much dose iodine for the kidneys and also radiation. But most importantly, is, as I pointed out, 50% of the patients who are candidates for TPA, for IV therapy, and who may have residual clot, that clot may not be seen on a CT angio or MRA. It could be distal. So a large percentage of patients would be excluded. Now, if we do this study and show that it's safe, and then do a subsequent study, and maybe that such a study wouldn't be positive, and we need to have it more targeted. But I see this double dose strategy as something that could be used in any hospital, that gives IV TPA. So it'd be much more generalizable than if we required imaging in order to select our patients. So that's why we designed this trial this way. So in summary, IV therapy is not going to disappear. It's an effective therapy, but it only reaches 10% of patients with ischemic stroke, and at least half of treated patients remain disabled. I think, as I pointed out earlier, doubling the number of patients we can treat will have a greater impact than any new permutation of IV therapy. I think community education works. It's only modestly successful. I don't have time to talk about this, but I think targeting and enabling treatment of patients on DOACs, 20% of the patients that we see that may be candidates for IV therapy we can't treat because they're on DOAC. So we got to solve that. And then, of course, maybe there are early warning technologies that we can use, and more mobile stroke units to get more patients treated. I think speeding IV therapy is the most powerful way to improve on therapy, and mobile stroke units are shown to work. They are cost effective, but reimbursement needs to be solved. And in urban areas, I think treatment in that first hour has got to be the ideal, certainly within the first 2 hours. That's where all the action is. In rural areas, mobile stroke units can increase our treatment and speed our treatment even more in rural areas than in urban areas, and can produce even greater time savings. And I think that stronger therapy is where the field is moving. I think deserves further study. I think residual disability, I think it's clear, is due to residual clot in the macro or micro circulation. And I think preliminary data show that additional intra-arterial thrombolytics in patients who are undergoing endovascular therapy, or a second IV dose are safe. And I'll point out, there's no reason to think that an IA dose is any better than an IV dose. As I pointed out, the drug gets to the clot either way. It binds to fibrin immediately. If you've got the catheter in there, you might as well give it intra-arterially, but you're doing just as much getting the drug to the clot by giving a second dose of intravenous therapy. So I do think that second dose strategy is safe and may be effective. So thank you. We'll stop at this point and be happy to answer questions. I want to thank you, Sean, for inviting me. And I know the fellows have heard this lecture multiple times, but maybe repetition will convince one or two of them to take on further study of these strategies, because I'm not going to be around doing the subsequent studies, but we'll get this pilot study done and get the treatment, and hopefully we'll get the treatment on the board so that you all can prove it's effective. So I'm happy to answer any questions.
Fantastic, Jim. There are several, I think, questions now starting to come through. So first one is, so Alberto Maud in El Paso runs the stroke program there. Can you give some advice to increase MSU acceptance and MSU utilization to reach more subjects in the community without increasing further the capital investment? As we know, El Paso has an MSU.
Right. Well, I don't know what the situation is in El Paso. Well, first of all, placement of the mobile stroke unit. The two things that you have to do is you have to get all the fire departments in your city to cooperate. And I don't know what the situation. I think El Paso has a single fire department, but if there are competing, like in Denver, for instance, the mobile stroke unit in Aurora at the University of Colorado can't pick up patients that the Denver Fire Department picks up within the city of Denver. Solving that and solving that sort of conundrum is a problem. And then competing hospitals. If a patient is in the some mobile stroke units might be reluctant to place their mobile stroke unit in the backyard of a competing hospital because they don't want to, quote unquote, steal their patients. But if that hospital's collaborating with you and you can deliver patients to any hospital with your mobile stroke unit and they aren't fighting against you, then you can place your mobile stroke unit where most of the stroke patients are. So that seems fundamental, but that's the most important thing. And then you have to constantly train the dispatchers. Mobile EMS dispatch is the Achilles heel of the mobile stroke unit program, because if the dispatcher doesn't identify the stroke, then the mobile stroke unit doesn't get dispatched. And furthermore, a lot of strokes, probably at least half the patients we treat, we're not dispatched for. The fire department arrives on scene, identifies it as a stroke, and then calls us. So training the fire department dispatchers to call you appropriately, and then training the medics to secondarily call you if they detect a stroke and you've not been dispatched. So that may or may not answer your question, but those are the things we've done in Houston to keep ourselves as busy as possible.
Great.
If I can see the chat about the fibrinogen level. There may be. I do think that it's a reasonable thought. I'm not sure that if the fibrinogen level is low, that would deter me. We just don't have enough data. I think maybe it would be worthwhile. We're getting TEG levels in our patients. We're going to obtain a TEG to see if there's any correlation to bleeding that occurs, because TEG can determines the amount of thrombolytic on board. But I think some biomarker of the amount of lytic activity on board when you give the second dose to see if that correlates with bleeding would be a reasonable thing to do. We haven't used fibrinogen level, but that would be reasonable.
I think the next one is coming from Farzan at Baylor Scott and White.
Not sure I see.
Thank you for the presentation. It was awesome. I just had two quick questions. For the study with the repeat doses, you may have answered this with the TEG, but are you going to exclude patients on dual antiplatelets or like okay? And then the other question was, you know, when we have pulmonary embolisms or big pulmonary embolisms causing right heart strain treated, the IR guys, they put them on a TPA infusion. So is that something, I don't think that's been studied in stroke, but is that something that should be looked at? Because then you can see if the clot's dissolving, if there's improvement.
Yeah, I think that I think an infusion of TP, the thing is with TNK, as you know, you don't have to give an infusion. That's what we seem to be using now. So with TNK, there's probably ways to give it differently than giving a second dose. Seems to me that it's logical to give the second dose at 45 to 60 minutes, but an infusion of Activase is reasonable. And you point out an important point. There are very few other diseases that we treat with a single dose of anything, even antibiotics that give the most, I mean, only the most sensitive, I guess syphilis, early syphilis, we use one dose of penicillin, and early strep throat, maybe. I don't even know whether that's still the case, but almost always we give repeated doses of our most effective treatments. So it's kind of logical to think that giving continued treatment would be useful for ischemic stroke. Now, are there other ways of doing it, like with an infusion? Possibly that would work better. I think with TNK, 2 boluses makes the most sense. But yes, this is a pilot study just looking at bleeding. So we're taking pains to exclude patients who might have an increased risk of bleeding. Like if a patient's been on dual antiplatelets, we're not going to include them. We're going to withhold antiplatelet therapy for 24 hours after we treat them, and not include patients with cognitive impairment for fear of including patients with be harboring amyloid, just for this pilot phase.
I think the next one is Ali Carroll.
Thank you very much, Dr. Grotta, for this amazing talk. I have kind of 2 questions. The first question in regard of mobile stroke unit and, including patients. Do you guys, or does your team currently treat those patients with tricky stroke conditions such as like painless vision loss, suspected like retinal artery occlusion, or isolated dizziness that come to you guys in the mobile stroke unit? And the other question is, the other question regarding like double dose TNK, I'm sorry, I have to mention the elephant in the room. What about patient with stroke mimics? Any plan to mitigate this, or should I tell, if I do have a bad conversation with my wife, should I just drive to the mobile stroke unit and all of a sudden my arm and leg is now working to get my double shot of TNK, or any plan to mitigate that, or what?
Well, when Heinrich Adebaer, and I have to shout out to Heinrich, of course, and Klaus Fassbender, because they did the first studies with mobile stroke units. And when they presented their data, the first question in my mind was, well, how do you know you're rushed to treat these patients and just have a CT scan, that the improvement isn't due to the fact you're treating more mimics? Are you doing just as good a job diagnosing the patient on the mobile stroke unit? Well, in our study where we compared treatment on the mobile stroke unit to treatment in the emergency department, the mimic rate was 9% in both groups. So we aren't treating more mimics in the mobile stroke unit that then get treated in the emergency room. As a matter of fact, I have found in the last year that I have delivered patients to the emergency room that I haven't treated on the mobile stroke unit, and then they get treated in the emergency room, and by our stroke fellows. And that's not a criticism of them. I think that, when we did a study, Sean, you probably part of it, if I remember correctly, where we had 2 stroke fellows go to the emergency room at the same time and blindly decide individually whether to treat a patient. And the agreement rate was only about 80%. So you know, there's always a subjectivity in deciding whether to treat a patient with thrombolytics. And we are going to treat some mimics. All I can say is that mimic rate none of the studies that have been done so far suggest that the mimic treatment rate is higher on mobile stroke units than not. But yeah, if we're going to use double dose TNK based on clinical criteria, we are going to, without requiring seeing the arterial occlusion, we probably will treat a few mimics. That's why it's so important to show that it's just as safe as giving a single dose, or certainly not substantially less safe.
There are some more questions in the chat.
The main conflict I have with early IVT and K for M1 occlusion is partition of the clot into two M2s. This increases procedural time and interprocedural complication rate. Well, you're right. I think that's one of the recognized things that's happening is that thrombolysis can lead to clot breakup. I don't know whether the net effect of that, though, is worse, because none of the studies where patients have been given IV therapy prior to endovascular therapy have shown worse outcomes. They haven't always shown better outcomes, particularly when the IV therapy is given in reasonably short interval of time before the IA. And quite honestly, if patients in the emergency room and my endovascular team is ready to take the patient upstairs, I'm okay with skipping the IV therapy if I know they're going to get the endovascular. But I don't really believe that the net effect of IV therapy is detrimental. And the patient I just showed you, if they had decided to take the patient up to, their NIH stroke scale score in this 96-year-old woman, I think by 24 hours, it was only 2. So even though the clot had moved distally, the outcome was much better than had that clot stayed proximally. So, but it's a legitimate question. But I don't think that we're having a net detrimental effect by giving IV prior to IA.
And Jim, there was a question above from Paul, I think in the UK. You see there.
I can't see it.
Oh, okay. It's talking about the question's about this idea of like rethrombolizing patients. So since you're been discussing that, you know, what's your comfort level about how soon could you rethrombolyze a patient after a recurrent stroke?
Yeah. Well, I would use this, honestly, I'd probably use the same correct. We don't know, right? Because we haven't treated patients, you know, most of the time within 3 months of a previous stroke, because that's one of the recommendations against it. I would not hesitate if I would go by on the CT scan. If I don't see any evidence of swelling, obviously any bleeding, the earliest, I will say, we have treated patients with second doses who had lacunar or subcortical strokes. And Sean, you may remember this back when we saw, as we all see, these subcortical fluctuators. There were occasional patients who come in with a subcortical stroke with a hemiparesis. We give them thrombolytics. They get better, maybe or because of the thrombolytics, maybe not. And then 12 hours later, they would have a recurrence of their hemiparesis. I have treated 1 or 2 of those patients after repeating the CT scan with the second dose. I'm not sure it helped, but it didn't hurt them. But I would be reluctant with a definite stroke to treat the patient within the first 2 or 3 weeks, no matter what. But maybe it could be safe if the patient has a subcortical stroke and no swelling. You know, and as you know, this whole landscape is changing in terms of how fast we can start anticoagulants in these patients. And we're starting anticoagulants earlier and earlier. We know we can reperfuse the artery by opening up, doing a carotid endarterectomy in patients after a stroke within the first 2 weeks and do that safely. So maybe we can give thrombolytics sooner than 3 months. That's another study that can be done. I don't know of any trials that's addressing that.
And then there's a question, Alberto was just asking, how many patients on the MSU get a CTA?
Right now, none, because we're changing our injector out. And it's a real problem because I want to do them. But I'd say about in our uh, uh, hands, probably about half. If we suspect there may be a LVO, so obviously if they have high NIH stroke scale score, or if they have cortical signs and a low NIH stroke scale score, we'll do a CT angio because, and the reason is not so much for triage because we only deliver to comprehensive stroke centers, but if you're in a place where the primary stroke centers are closer, it'll help you triage, but mainly to alert the endovascular team, hey, we have a definite LVO here, and get the team ready. And our endovascular teams are usually pretty responsive to that and are willing to take. And our CT angio cannot look predictably at the bifurcation, but we can see if the artery is open in the neck, the carotid is open in the neck, and that is good enough for most of our interventionists to proceed without seeing the bifurcation.
Does getting the CTA, how much it prolongs the time?
It takes about 8 minutes to do the CT angio and look at it. And I think I was surprised, quite honestly. The ceratome is the slices are thick, and I was thinking that we probably would not be able to see LVOs predictably, but I think that we've been pretty good at seeing LVOs. Now, I think that AI will help us with the MEVOs and the distal occlusions if it comes to the point where identifying a MEVO will change our management, and definitely patients would definitely go to endovascular. I think if I had a MEVO, I think most of our interventionists would probably want to repeat the CT angio before taking the patient. Maybe not.
Ali, did you have one more question?
Actually, I have a question, Dr. Grotta.
Oleg.
This is
Hey.
yes, Oleg speaking. Yes.
Hey, Oleg.
Yes, I remember our good times of Caffeinol and neuroprotection ideas. Maybe that's what we need to combine with TNKs. We never done anything with TNKs like that.
Well, I think neuroprotection is still, whether it's Caffeinol is a not to bore you all, but was a combination of caffeine and ethanol that we studied in the lab and even clinically, but never really got traction because it was not sexy enough to get funded. But the point is, I do think that there's a role for neuroprotection, but having labored in the neuroprotection fields for years, I think the bang for the buck is better reperfusion. And that's where I think that, using the strategies I've mentioned are where I would choose if I was going to put my money on where the efforts should be placed. But I do think that imaginative approaches to newer neuroprotective strategies for in patients who get reperfused would be useful. And but I think that, and this is something I tried to articulate at the last STARE meeting. Don't think I did it well enough, but I think that interesting thing about the large core trials is the fact that these patients improve who have established infarcts despite the fact with reperfusion, despite the fact that it looks like they've got, very large infarcts. Understanding why that happens and, to me might be a key to some neuroprotective strategies. I think that this may be an endothelial thing that where and at the microcirculatory level that's not evident at the CT macro level where we're seeing large infarcts, but that maybe by reperfusing in the microcirculation, we're improving reperfusion to the endothelium and preserving endothelium and maybe then the collateral flow. I just don't know, but I think that the blood vessel wall, to me, is if I'm going to protect something, the easiest thing to protect is the blood vessel wall. I know the drug can get to the blood vessel wall a lot easier than it can get to a struggling ischemic neuron. And I think we've neglected, I think that the field should look at trying to do endothelial protection.
Or maybe transcranial magnetic stimulation can, shake up the tissue, right, along for distal occlusions and, non-large vessel occlusion.
And we come back to clockwise and maybe ultrasound. I mean, I do think that, there's plenty of room for novel strategies, no question about it. So for the fellows on the call who are just starting their career, I know you hear this all the time, but use your imagination, because there's plenty of things to do out there. Even though we've achieved success in some of our patients, there's as I think I've overemphasized, we can do better. Okay. Well, thank you very much. Appreciate the attention and the questions, and nice to hear and see some old friends on the call.
Thanks so much, Jim. Fantastic talk. Thank you. Thanks,
See ya.
everyone.